molecular imaging of the Singapore General Hospital for 35 years. His secondary appointments are Hospital Radiation Safety Officer and also being the Operations Manager. He's QA Manager for the cyclotron facility of the positron tracers as well, besides being the Chief of the Radiation Response Team at the Singapore General Hospital. He also chairs several committees in radiation safety and medical physics education, both within Singapore, the regional countries, and for the IAEA. He is an active visiting lecturer and expert in nuclear medicine, radionuclide therapy, radiation physics, and the quality management in nuclear medicine, the production of PET radiopharmaceuticals for the IAEA for the last 25 years. He is actively involved in the education and training of nuclear medicine residents, medical physicists, radiographers, engineers, and nurses in Singapore. Welcome to Professor Samanasan, and please enjoy this presentation.
Greetings, dear Isrrt members. I wish to thank Mr. Steve Lassie, Director Isrrt Education, and Dr. Kitty Watt, Department of Radiology, Chulalongkorn University, for the invitation to give you this talk on administering targeted radionuclide therapy, safety and the quality management aspects of it. My name is Soma. I'm from Singapore General Hospital, and I have more than 3.5 decades of service in nuclear medicine as well as radiology, physics. A little bit of history about my hospital before we start. We had our humble beginnings in 1821, and we had our bicentennial celebrations during the COVID pandemic. Right, a bit more about my hospital. We have been in the top 5 listed hospitals by the Newsweek magazine for 5 years running. And with that, let us start with the objectives of today's talk. And this is what I'm going to be covering. What is Theranostics very quickly, and some objectives as well, and what is quality management. And this section summarizes how quality management can mitigate radiation hazard, improve radiation safety, improve patient outcome, prevent wastage of radiopharmaceuticals, consistent results that you cannot expect, and of course the importance of QM in targeted radionuclide therapy service delivery. We wish to also understand how quantum or quality management services in nuclear medicine advances Theranostics service delivery as well. I'm going to switch off my video for a better bandwidth. Precision medicine basically identifies which approach will be effective for which patient based on genetic, environmental, and lifestyle factors. So molecular diagnostics refers to imaging and analytical softwares that are employed for selecting appropriate and optimal therapies based on the context of the patient. Now, what is precision medicine in nuclear medicine? Well, our answer is Theranostics. This is basically a term that was coined back in 2002 by John, and basically he used the two parts of therapy and Gnostics and put it together in Theranostics, the state-of-the-art treatment in modern nuclear medicine. Now, what is Theranostics? In essence, this diagram summarizes the therapeutic approach in nuclear medicine, which following components and their respective radioisotopes have advantages. Some have diagnostic as well. For example, this portion, and if you can look at it over here on the left-hand side, you have technetium, you have your fluorine-18 and gallium as well. These are used for diagnostic aspects, as well as on the right-hand side, you see the arsenal. Basically, the beta emitters at the top and the alpha emitters at below in yellow. Both of them are basically used for the therapy aspects. Now, these theranostic pairs are basically nuclides which can be used for imaging as well as those that are used for therapy, and they both have a specific molecule to bind. For example, some of them could be PSMA or NET as well. Now, these are common Theranostics pairs, which I've got lifted it from the radiographics. For example, let's just take one of them here. If you look at the second last one, gallium PSMA or fluorine PSMA, these are the diagnostic agents used in PET-CT imaging of such patients. And on the arsenal side or the therapeutic agent side, you have the lutetium and actinium PSMA. So the target is always the PSMA and of course the prostate cancer. Right, so like that there are many other therapeutic as well as diagnostic agents. Now, the aim of Theranostics is to provide a personalized precision care, as I had mentioned before, to deliver the right treatment to the right patient at the right time with the right dose as well, aimed at the same target-specific biological pathway or receptor. An accurate quantification of the tracer distribution can be obtained, which helps prescribe the therapeutic dose for each patient. Post-treatment imaging confirms whether the tumor has been treated or the metastatic sites have been removed. For example, if you look at this PSMA, it's not very clear, of course. You can see this is the first one is gallium PSMA, and then with the treatment which is provided by the lutetium PSMA, you can see the patient has become disease-free after a couple of cycles of this. Now, let's talk about quality management in nuclear medicine, the basics. First of all, if you can look at this diagram here, you have 4 components inside here: quality planning, quality assurance, quality control, and quality improvement. In essence, targeted radionuclide therapy service delivery is catered by nuclear medicine. QM has 4 components, as I just mentioned them. QM is focused not only on service quality but also on the means to achieve this service quality. Quality management therefore uses quality assurance and the control of processes as well as products to achieve a more consistent quality. Quality management audits in nuclear medicine, or QANM in short, coined by the IAEA, in short, was created by the agency to help improve the quality management of nuclear medicine departments throughout the world. Why quality management is specifically important in targeted radionuclide therapy? Well, that might be a good question that you may have. Well, it improves patient care, safety, and outcome. It improves patient and staff satisfaction. It makes the best use of available resources, and also to prevent wastage. As you realize that lutetium and actinium for PSMA, or for that matter peptide therapy, is not cheap. They are in the same realms as some of the medical oncology drugs that are used in cancer care. Improve visibility of and the confidence in nuclear medicine in the local, regional, and national setting. High ablative radiation doses are utilized in therapy, where patient receives about more than 30 milligray of radiation to the organ, and compared to diagnostic nuclear medicine, where bone scans or thyroid scans or radiology of CT abdomen or CT head is concerned. So in that sense, a huge amount of radioactivity is provided to these patients, resulting in a high absorbed doses, and therefore we just can't make any mistakes. Improve tracking of patient disease management, and instill a safety culture among the staff in targeted radionuclide therapy. Right, QM ensures that targeted radionuclide therapy service delivery provides consistent service, improve patient care and outcome, radiation safety, and prevention. So basically, QANM identify areas for improvement, identify major problems and opportunity to correct the inaccuracies. In essence, the idea is focus on quality, basically. So The quantum has been around for some time, and in fact, it has already reached the third version of the original document, which was started more than 10 years ago. So now we are on version 3.0. In essence, there is a list of checklists provided by the agency, created by the agency, by member states, and basically you need to look for conformance and non-conformance in each of these checklist items, and there could be about 200 questions or so, and going through the checklist would help us grade whether how the department or center is doing according to international standards. There is a digital format where there is a graphical use of colors for non-compliances, and at the end, after you've finished the each of the checklists, there is a polar plot that is produced that helps to quantify the results of the center. So the scales of 0 to 4 are provided, where 0 to 2 they are red in color, that corresponds to the red sections that is over here, for example, and the greens are basically largely conform and fully conform if the department is doing well. Right. With that, let's jump straight into quality management in nuclear medicine, a synopsis and the practical aspects, especially slanted towards targeted radionuclide therapy. Right. In essence, when you have theranostics, you need to do imaging. You need to do good imaging as well. So, of course, the equipment that you purchase needs to have properly accepted, properly commissioned by the medical physicists and engineers, for attenuation correction, for example, the alignment between the SPECT and the PET with the CT component needs to be checked periodically as well. The sensitivity, the calibration overflow can differ significantly between vendors, and that needs to be checked as well. And of course, if you can look at this is a poor uniformity image of the yesteryears when we were using circular detectors. And this is from the IAQC Atlas, where you can see there's an artifact as a result. Okay, so of course, as technologists and radiographers, we need to be aware of the action thresholds. For example, how bad is bad? How bad is it usable? For example, on a daily differential uniformity, is it less than 3%? If it is, then it's acceptable for use in SPECT imaging as well as planar imaging. If it is greater than 3%, then something warrants to be checked, and perhaps you need to call in the physicist or the engineer to take a look at the detector, right? So who makes these decisions of whether the scanner can be utilized on a daily basis? Well, it could be the manager in the radiography department, or results to be documented and needs to be archived as well, perhaps in the PACS, perhaps in a written form as well. Okay. And talking about implementation of QA/QC, in essence, if you look at the nuclear medicine technologists' main duties is to assist in the performance of QC procedures, comply with local QC program that is developed by the institute or nationally accepted, prepare the appropriate sources, and use standardized parameters for acquisition, patient acquisition, to be aware of the action thresholds, for example, as we just spoke about, how bad is usable, etc. And now, important aspect of imaging is patient identification in radionuclide therapy, and you just can't be making any mistakes on this aspect. Are there standard SOPs and written instructions available to ensure correct identification of the patient prior to the administration of the radiopharmaceuticals? The usual 5 R's cannot be emphasized any further. Right patient, right theranostic radiopharmaceutical, right activity, right time, and right site as well. And careful identification of patient, for example, be prepared for emergency situation. Questions to the patient is whether they likely to be pregnant, female patients, or they were breastfeeding, If they are incontinent, because we do not want to have a spill, a radioactive urine spill in the department post-treatment, whether the patient is nausea, these kind of clinical indications would help to mitigate anything that might happen post-treatment. Whether there are SOPs in place based on national guidelines and or institution guidelines, are SOPs available for patient preparation regarding all types of treatments? Is a decision to treat based on multidisciplinary evaluation of the patient's condition and fully approved by the NM physician in charge of the treatment? Does every patient receive information about the treatment, including um, uh, including alternative treatment options, the need to stop lactation if possible, if necessary, etc. Is an SOP in place to rule out pregnancy and to deal with lactation before therapy? Does the patient information include instructions on necessity and duration of ongoing contraception post-treatment? Are procedures in place describing the process of obtaining informed consent before therapy? Is the therapeutic activity prescribed taking into account the target to non-target ratio? Basically, there's an internal dosimetry being performed, and whether it's accurate and whether it's personalized for the particular patient. So I don't have to say anything further about internal dosimetry, and that's the cornerstone of personalized medicine, because no one size fits all in essence, and basically you need to have sequential imaging and then a curve fitting to improve the accuracy of the residence time, and then you plot these into a program to obtain the absorbed dose estimation. You could use something like Olinda, for example, and of course they are better, more accurate three-dimensional dosimetry that is available these days. Quantitative nuclear medicine, I put this slide here because to understand that the aim of quantitative nuclear med is to plan the alpha and beta emitting therapy based on an accurate 3D representation of the in vivo distribution of their radioactivity concentration, especially when we are dealing with PET-CT theranostic pairs, which, for example, are like fluorine 18 and gallium 68 based pharmaceuticals. The separate gamma and the beta alpha decay modes of lutetium 177 and actinium 225 allow for the imaging of the activity distribution and calculation of the dose distribution, assess the metabolic status of the disease for diagnostic staging, treatment monitoring, the disease progression, and that needs to be optimized with SPECT-CT by internal dosimetry, for example. Now, the QA in diagnostic procedures, we don't have to say any further, because we need to perform all the clinical nuclear med procedures and provide high quality diagnostic images by allowing appropriate time to lapse between the administration and imaging, for example. That means there's consistent uptake, especially for sequential imaging, so that you can compare the sequential images more accurately. And the setting up of the protocol, we cannot make mistakes between gallium PSMA and F18 FDG, for example. So they are separate protocols, acquisition, the iteration sets, etc. So they cannot be mixed match. So another thing is the adopting the protocols for patient condition, patient size, for example. The FDG is based on the injected FDG dose is based on the patient size. Identifying abnormal distribution is significant as well. And not forgetting that SPECT-CT in targeted radionuclear therapy improves dosimetry estimates, tumor and organ volumes, iterative reconstruction is utilized, modeling of non-uniform activity distribution, and to help us with the estimate the dose delivered to the target region more accurately. The factors which influence SUV, all of us know that the technical aspect is the calibration of the scanner and the dose calibrator, the check the synchronization, the residual activity as well. In terms of patient, the uptake period, whether the blood glucose was controlled, the diabetes maintenance, inflammation, patient organ motion as well. And finally, the FTG dose, scan duration. So in essence, the imaging has to be top-notch when we are dealing with targeted radionuclide therapy. Now, the harmonization of activity measurement, we'll spoke very little bit about this in the last slide. In essence, the well counter calibration, where the dose calibrator is calibrated with the PET scanner, and this needs to be done every 3 months minimum, after every preventive maintenance or so as to make sure that the what the SUVs are accurate. Yeah, so every manufacturer of the PET-CT scanner has their own phantom, and that needs to be performed by the physicist or the technologist regularly. Way of the clinical studies post imaging, the correct use of equipment, for example, and standard and consistent techniques and methods in the clinical settings is utilized. NMTs play a key role in establishing clinical standards and protocols. And advantages of protocols for theranostic pair is to make the responsibilities clear, who does what when, enable the audit procedure where documented steps are being reviewed, provide a consistent presentation of data, use standard checklists for theranostic paired procedures that will help us so that we don't miss out on any of the steps, can allow some room for professional judgment where you can voice out if something goes wrong. For example, if a tech sees a artifact during imaging, for example. So with that, let's jump on to the QM aspects in radiopharmacy practice and activity determination as well. Very quickly, all radiopharmaceuticals are prepared following high quality standards, both the therapeutic as well as the diagnostic radiopharmaceuticals. The key principles are good radiopharmacy practice is carried out and recorded by trained and qualified nuclear medicine technologists or radiochemists or radiopharmacists, depending on your country, adhering to safety standards. Adequate facilities should be utilized, where, for example, the IO radiopharmacy lab classification 1A to 3C are utilized accordingly for the different grades of work that is being done. Suitable equipments are available. For example, a PSC, a shielded PSC with laminar flow for drawing the prepared doses, for example, to provide a combination of personal protection as well as product aseptic practices. Suitable materials are available, for example, lab supplies, the PPEs, shields, transport containers, they are all available of the sufficient type and sufficient numbers of them, and written SOPs are present as well for every aspects of the work. For example, in every type of radiopharmaceutical compounding or synthesis, and also drawing out doses aseptically. QC measures of a radiopharmaceutical synthesis is the administered activity individually measured and checked in an activity meter, which has been specifically calibrated and checked routinely for the given radionuclide. Is there linearity done? At the same time, is constancy done for these dose calibrators with the various radionuclides? Is there a written SOP describing the procurement, preparation, and quality control, if applicable, of the therapeutic radiopharmaceutical or radionuclide that is utilized? Are SOPs and records of radiopharmaceutical synthesis available in the department? This is the QC tests such as constancy, accuracy, linearity, and geometry are done on a regular interval as well. And in terms of QA in therapeutic procedures, is there a nuclear medicine technologist or radiographer, physicist, nurse, and doctor confirm that the administration can go ahead safely by checking the request was approved by the referring physician, the dose was validated by the physicist in some centers, for example, and patient's identity and corrections are prepared for possible check for possible pregnancy and breastfeeding. The patient receive appropriate instructions and explanation. The radionuclide and the activity is prescribed before the patient dose is prepared and measured as well. So aftercare, well, perform the radiation monitoring of the area, equipment, and patients as required by the institution or the national level regulations. Document the administration according to the department policy protocol. And with that, we skip over to the radiation safety and targeted radionuclide therapy delivery aspects. Right. Now, the factors that affect radiation safety in TRT service delivery, all of them are listed here, and I'm sure you're well aware of this. We spoke a little bit about the radiopharmacy. Well, the radiation safety in the radiopharmacy starts off from the ordering processes, the receipt and the unpacking, the storage, the dispensing, the internal transport, the radioactive waste management, and when we are talking about the injecting in them into the patients, the safe administration, we need to look for the correct patient identity, the right patient, right scan, right radiopharmaceutical. Check for pregnancy if she's a female and breastfeeding, and patient infusion as well. And of course, on the right hand side, you see the patient preparation, how the patient is prepared, and hospitalized patient, the instructions to them very clear in the native language of the patient. Provided by the nursing staff, other visitors' instructions very clear, and they are known to the patient as well as the next of kin. And of course, how to discharge these patients, decommissioning of the hospital ward post usage, so that the room can be turned around for the next patient the following week or following few days. And of course, radioactive waste management. And of course, we need to be ever vigilant for any of the emergency procedures, like a death of a TRT patient or decontamination of an alpha or a beta spill. Right. The facility for inpatient TRT. So some centers require, especially in Europe, where the TRT patients need to be warded in a room, such as this, for example, with a shield around, so that when a nurse comes around, patient does not irradiate the nurse unnecessarily. Okay? So with the signs outside, etc. But there are many centers where we, especially with the newer radionuclides such as lutetium or actinium, or for that matter the yttrium-90, used with PSMA or peptide treatment for castrate-resistant prostate cancer and neuroendocrine cancer respectively. They are increasingly, many centers are doing it on an outpatient basis, where the treatment is done in the nuclear medicine facility room with the proper surroundings, as well as some shields as well, so that when the patient is in the department for 2 hours to 3 hours, is well looked after, and he doesn't irradiate the nearby other patients or staff as well. So there should be a nearby toilet for the personal use of these patients as well. Right. How do we do this alpha and beta TRT delivery? Well, the route of delivery is either intravenous or infusion based. It could be a syringe pump or an infusion pump utilized. Some centers use gravity to infuse this radiopharmaceuticals, which sometimes require half an hour or 20 minutes of infusion of a large volume of 20 to 50 milliliters. Now, what we have is that we have actually we use the infusion pump in Singapore General Hospital, and is used to in a customized infusion trolley such as this. This is a schematic of it, and this is how it looks like. It looks stainless steel, so it's easy to wipe and sterilize as well. And this is a side profile which has got a drip for hanging the saline bag, for example. This is nothing more than a L block that we bought, the old Biodex L block, and we encladed it stainless steel. You can actually see the silhouette of the patient on the stainless steel back, right? So the patient is on this side while the nurse is on this side while she handles the infusion pump, which is within the this enclosure. Right, so this is a typical infusion pump, for example, with a 50 milliliter syringe there. Right, so here basically the treatment room can be quite a distance from the radiopharmacy, so it has to be safely brought to the either the inpatient facility or the outpatient treatment room, where a transport trolley such as this can be brought. It can be a motorized trolley, otherwise it's manually pushed, and then once it is reached the destination, you transfer it over to the infusion trolley, where the nurse then would set up the infusion pump with all the lines, make sure they are all well primed before the treatment is commenced. And a physician then checks on the patient to see whether the patient is well prepared for the radionuclide therapy. So once the treatment is started, the nurse would spend a little less time in close proximity to the patient, so as for radiation safety. But of course, the patient is monitored throughout the procedure, like BP, etc. is monitored throughout. Right. So this is a syringe pump with a syringe here with a radioactive 50 ml syringe, and this white portion is basically a lead semicircular block that's sitting on top of the syringe shield to cut down the exposure to the nurse who is standing behind the cell shield, so to reduce the extremity dose. Now, with that, I wish to continue about radiation safety, but this time I'll talk about the contamination control and decontamination processes. Now, the general precautions in managing targeted radionuclide therapy, well, they are where EPDs or electronic personal transmitters, besides your OSL and the TLDs, no pregnant staff if radiation exposure is expected to be greater than 80 microsievert per hour, which varies country to country as well. Always use PPE when handling body fluids. We never know when the contamination might arise. Where possible, no food and drink for staff till proper decontamination is done and checks are done as well. Provide disposable cutlery to patients so it can dispose in general waste after utilization. Practice good housekeeping and clean work habits that we basically need to do, especially COVID has taught us this sort of requirements as well. And with that, I'll talk about the radiation regulations and safety compliance in the pharmacy. Are there adequate facilities for the administration of radiopharmaceuticals, therapy ligands, and the radioactive aerosols if they are necessary, including radiation protection tools if necessary as well? And is there a procedure for regular monitoring of workplace contamination? Is there ways of checking is there a wipe test or a survey test on a regular basis, a couple of times a day after the use of the facility to ensure that we can catch any spill before it contaminates our colleagues and other staff. So the basic protection in radiation contamination is 3 basic PPEs will provide you with the skin protection against radioactive particulates, contamination which potentially are the main source of hazard as compared to the exposure, and less contamination means less exposure. And on leaving the inpatient room, protective clothing must be removed so as not to contaminate the other parts of the facility. Use your standard universal infection control and precautions and PPE, face masks and shield splash if necessary only. And gloves, I generally recommend double gloves as well, and a gown to protect the scrub suits, and the shoe covers where necessary. A decontamination kit for radioactive contamination consists of regular items such as head cover, the disposable gown, paper towels, oversoles, gloves, the usual scrubbing scrubbers, as well as a liquid soap solution, and cotton pads, etc., labels, and waste bags and masks as well. So all these items are regular items that you can get from the pharmacy or the material management department of your hospital or a supermarket. But in essence, all of them need to be put in a container and kept, and that everybody knows where they are. So there should be many of them, not just one in the whole department, but pretty much every room where there is a likelihood of a contamination should have this sort of a decontamination kit, and it should be checked whether all the items are present on a regular basis, so that when you really want it, you can have the full access of this kit as well. So what we do is we put them all into a Tupperware and leave them in the cupboards. Waste disposal and environmental monitoring. Well, the regular radiation monitoring after the radio labeling has to be performed. Clear strategies for the separation of radioactive and non-radioactive waste needs to be done. Records of radioactive waste disposal. This is as per your national requirements. Removal of the radiation signs before the final disposal, especially when they have decayed down. So the waste management program is in place according to national regulations. So what we have here is a sharp box that is utilized for sharps, and it is encased around by lead blocks so as to cut down the exposure around. Management of waste. This is another little container with lots of gloves. As you can see, these are non-sharps, and this is a sharps waste, radioactive waste. Both of them are radioactive, and they're collected as such. Are the radiation signs such as these available and in all the languages that are that can be understood by the staff in that facility? Are there formal procedures provided for the management, storage, and the disposal of the liquid and solid waste, including considerations of chemical and biological hazard safety aspects, because some of these pharmaceuticals may be either acidic or corrosive or biohazardous, and they need to be handled accordingly as well. So they will have both the radiation hazard as well as a biological hazard as well. Is the level of waste regularly checked against the authorized disposal limit and recorded? And is there a policy on the transportation of these within the hospital and out of the hospital? And do all personnel receive instructions and training on local procedures, safety precautions for the protection of the patient and the staff when they start working in the nuclear medicine departments? So with that, let us talk about the nursing care, the radiation safety in nursing care, and discharge of the targeted radionuclide therapy patients as well. Right, the nursing care of the patients involved in case of inpatient therapy, a 24-hour nursing care needs to be provided. Has the nursing staff received appropriate training in radiation science, radiation protection, and do they have monitors on them to check how much exposure they receive? Do they know how to use the survey meters, etc.? In case of inpatient therapy, is qualified staff accessible for managing medical emergency situations 24 hours a day? In case of inpatient therapy, is a qualified person available outside normal working hours to handle urgent radio protection issues? You cannot be calling the physicist in the middle of the night, right? So are there specific SOPs dealing with misadministration of therapeutic radiopharmaceuticals as well? Now, the discharge of targeted radionuclide therapy patients varies countries to countries. I will highlight that. Is patient's activity admitted, dose rate measured and recorded in the patient's file before discharge from the service? Are written instructions provided, and are they in the language that is understood by the patients and the next of kin? Are procedures in place to make sure that these instructions are understood? Is a comprehensive treatment report issued and made available to all involved physicians and applicable to the patients? Do SOPs provide clear instructions for discharging these patients as well? So these are all part of the quantum checklist, and that can be utilized not just for NM, but also for targeted radiotherapy service delivery. Of course, we need to be prepared for any contingency. Safety assessment needs to be performed to it might reveal possible situations where emergency actions needs to be taken. For example, when there's a loss or damage of a radioactive material, spillage of radioactive material, very often it happens in nuclear medicine, medical emergencies like a fire, and of course, unfortunately, if there's an event of a death of such a patient with radionuclides inside them, ensure that the attending personnel receive as low as possible at all stages during either the burial or the cremation, and certain levels of radioactivity are not prohibited from being cremated as well. Precautions given are dependent on the residual activity of the advice, and this is the UK levels of for burial, the maximum radioactivity in the patient for burial as well as for cremation as well. And detailed contingency plans covering the actions to be taken in any foreseeable accident should be available. So that's something like ICU settings. Many of our patients do end up in the ICU because of their progressing disease. It may not be because of the radionuclide therapy, but it could be because of their cancer, for example. And if such patients end up in the ICU nurses need to know how to handle these therapy patients. So of course they are not monitored and they do not have any skill sets that are similar to nuclear med nurses. So you need to have SOPs, you need to have practices, you need to ensure that the ICU nurse is comfortable with handling these patients. To ensure SOPs in case of emergencies for both medical, physiological, radioprotection issues as well. We need to also encourage a non-punitive reporting culture for hits and misses and investigate every accident, incidents, and the near misses as well, and undertake a root cause analysis. It could be by a simple 5 whys, when keep asking why, and you get to the root cause of the accident or incident, and report SREs to the authorities as per your requirements in the regulations, and of course participate in IEA, Saffron, Astro to log in your default, your mistakes, so all the incidents and accidents that have occurred, and of course we need to counsel errand staff, find out the issues for their distraction if that is the reason for the mistake or the incident. Right, key words in improving our Theranostics service delivery is step back, think, and discuss among yourselves, among your team, on what went wrong, what went right, critical reflection of the process, quality, as well as profession and practice. Now, I wish to highlight that QA refers to striving for excellence, a continuing effort to reach the highest standard of practice in what we can offer to our patients. That is influenced by every member of the multifaceted team, because targeted radionuclide therapy is not done by one group of people, not just by the doctors or the radiographers or technologists or physicists or pharmacists or nurses. So all of them have to work in tandem for this sort of service delivery to be done efficiently, effectively, for our patients. And with each player playing their specific roles, this task can vary from country to country, because a physicist may be responsible in a country for a particular assessment or particular task. In another country, it might be a pharmacist or the technologist. Education and training, well, it's a lifelong learning. Who is concerned? All aspects of nuclear medicine are concerned. Why is it required? I think you know that. To ensure staff are properly trained in handling radioactive sources, they are familiar with the local risk assessment processes, ensure all diagnostic and therapeutic procedures according to relevant legislation and best radiation practices in nuclear med, and observe safety procedures daily in nuclear medicine as well. I wish to summarize and say the significance of quality management in targeted radionuclide therapy service delivery, how important it is, and the quantum process to improve patient care, treatment efficacy, and the radiation safety in targeted radionuclide therapy, and the proper management of radioactive waste was discussed, and the use of quantum helps in the careful planning, implementation of a cost-effective design while maintaining radiation safety standards in TRT service delivery. QM mitigates the radiation risk, ensures risk is outweighed by the benefit of the procedure, and the radiation protection procedures for TRT patients are needed. The radiation burden to attending staff shall be kept as low as possible to ensure contamination risk is mitigated. And the best approach is to keep ALARA, as all of you know as well. References and by having annual training and also competency assessment as well. So it involves both theory as well as some MCQ questions, followed by practical assessment of the skill imparted on the staff, because it's not very often that we have these bills. So, but they would need to know when it happens. So we have this assessment, and it's done on an annual basis in our country, and it's also regulated by the regulations as well.
And do the staff actually have an opportunity to learn from specific incidences that may occur within the organization?
Absolutely. That's correct. Yeah. That's absolutely right, because things that's like the nuclear med doctor and the nurses and the radiographers or physicists and the chemists, they may have different situations where it occurs, the spill occurs. So we bring the training to something more specific to where it might occur. For example, in the radiopharmacy laboratory for the pharmacists, for example, that's where we would do the assessment.
Okay. And I must admit, I'm a diagnostic radiographer, so I don't have a lot of experience with Theranostics. But is there a process whereby, if an incident occurs, that people not only within the organization or within Singapore, for example, those people abroad in other parts of the world, can they learn from those types of, say, is there some sort of reporting structure, or at least some sort of educational structure that allows people from other countries to be able to understand some of the incidences and how they can learn from those?
Well, that's a good question. We don't have a formal process established, but we have informal assessments as well as after incident, and how we mitigate this particular incident, and then try to find out the root cause of the incident as well. So we have that informal setup, and we do document it as well with photographs and also typed aspects of it. We're willing to share that if there's an opportunity for us to do that.
Yeah, and I guess, of course, with all of the incidences that can and do occur, not just within your organization, but in other organizations,
Sure.
and that helps to improve the process of making sure that your safety SOPs, I guess, are
Yes.
Are quite watertight, I guess.
So, yes, and it's not something that we start off from day one. We have all these things. Because of these incidents, we learn. And because we learn and we're able to adapt and hence create SOPs so that if it happens again, we can manage it better.
Yeah. No, that's really wonderful to hear, I think, anyway. And that just to finish off, do you have any last minute tips for people who are working in this area in terms of the quality management?
Well, there's only one thing that I wish to highlight as well. Just keep learning, keep improving your practice, and end of the day, your patient will be better managed and your staff will have lower exposure, and there will be good camaraderie among the team as well.
Excellent. Associate Professor Samana Sen, thank you so much for sharing your wisdom with us, and that it has been a really wonderful webinar. And thank you to everyone online for joining. It's great to see so many people joining online. Like I said, if you haven't joined the mailing list yet, please scan the QR code and do so. So that way we can actually target you more as far as providing you with the education. Associate Professor, thank you very much again.
Thank you.
And good day to everyone. Thank you.
Bye.